Grossing of the large intestine, part 2. This shall be mostly confined to the tumor, particularly the malignancy. This I have already said, have it in mind. Perceptions matter. Kindly have a look at this picture and see what all you can find. So also in a specimen, what one person finds might not be seen by another. Fundamentals are fundamentals. Always a request form with good detail is mandatory. Look at the panel of details that might be of great use to the pathologist and to the forthcoming diagnosis. These are all things which are essential. So much so that even a photograph of a specimen is being mentioned. Otherwise, a line diagram would at least suffice. And from where I had given the bits. So these are the various types by which we will be able to give a grading. When it is going to be confined to the mucosa and when it is completely involved and then it is traversing even further. So this grading can be of use. Microscopic examination. Common sense always matters. There can be non-neoplastic lesions, which we had mentioned earlier. We need detailed guidelines and there are many pathological mimicries. For example, in IBD also, there can be skip lesions in the case of ulcerative colitis that has been incompletely treated. Granuloma need not always mean tuberculosis or Crohn's disease. There can be other things. And other micro and macro features must be examined critically. Treatment history. Steroids in the case of ulcerative colitis. And any previous treatment should also be borne in mind. So these are the things which we had mentioned earlier. The gross and the microscopy and the other details. If the simple things in life don't make you smile, then you will never be happy. So I am generally happy when I have done a good job of grossing, including this. You look at this particular specimen, I am looking at it from the external. And this is a pad of fat, this is the serosa that is being cut. And look at it, there is a grayish white area that is projecting through the serosal surface, which directly means it belongs to T4. Therefore, external examination matters. So also the peritoneal involvement and the circumferential margin, etc. Some amount of it is needed. For example, this is a specimen. So there can be the various components that we had mentioned earlier. The small intestine, ascending colon, transverse, descending, sigmoid, and the rectum. And there are parts of it which are being covered by the mesentery and some parts which are not, which are called the bare areas. And there are also the peritoneal reflections, and these are notorious areas where there can be deposits of tumor we should be having in mind. And always when a bit is given, even in a downward one, to what extent it extends matters. So these are the important subheadings we should be having in mind. And externally, even before opening, what I am supposed to see is to palpate. Generally, a specimen is clipped and it is filled with 10% formalin, kept for fixation in again 10 times the fixatives, so that both the mucosa as well as the external surface are fixed. After which there can be an open. Before which, however, I will have to palpate. Look whether there is a bulk outside, whether there is any perforation, an exudate, so on and so forth, any diverticle, or a traumatic injury. In this case, I find that there is a mesenteric fat. So This will be what is called as the paracolic region, in which there is a first group of lymph nodes. And the external surface that also has to be examined. So these are important things that we like to see, and it is generally opened along the antimesenteric wall. Usually the non-peritonite surface is painted with silver nitride or India ink, and a nick is made below the incision. When there is a bulk of tumor, what we do is usually make a nick above the tumor and below the tumor, and with a wisp of cotton, there is a filling with formalin for fixation. Later, it can be opened up and kept in a cardboard for complete fixation. Look at this particular one. On opening up, whether it is neoplastic or non-neoplastic, always your eyes should be able to find out something. Look at, for example, this is the thickness of the wall, which will be of great importance. And there is an area of narrowing over here. And though it is cut, it is not widening. That is because of some kind of a stricture over here. And this again is reflected by the mucosa in a radiating manner that we see in a case of a peptic ulcer. So here there is a chronic inflammation that is pulling the mucosa. Whereas on the contrary, these are all perpendicular to the longitudinal axis, which is quite normal. Externally, always look for a creeping fat, and in the mucosa, a cobblestone, etc. When there is going to be an occult bleeding, you people should be filled with some kind of an incomplete knowledge so that you can rule out an angiodysplasia, ectatic blood vessels, any of the trauma or anything, what the surgeon has seen, what the radiologist has found out, etc. And if necessary, there can be a contrast injection that is given, which can display the vessels later on for our grossing. The bowel, as I told you, is fixed with formalin and it is studied. Always after opening, it is better to study with a hand lens so that trivial lesions can be found. This is a picture. Here, we will not imagine that there is going to be a lot of blood vessels, but look at this one. After injection with a contrast media in one area, there is a lot of collateral circulation so that all the vessels get filled and you are able to identify. This is of great importance because the artery, the vein, and the lymphatics all go hand in hand. And this is the cut surface of the intestine. The macroscopic examination will be the whole story of what is the nature of the specimen, what are the dimensions, and the distance from the resected margin, the tumor, again, the length, breadth, etc. And on description, what is the color, what is the friability, and going through the mucosa to what extent it spreads. All these are important. And whether there is any perforation, any abnormality in the background of polyps, for example, then you have got an adenocarcinoma. So there will be the bits that will have to be given that I'll be showing you in the picture as such. So this can be for the Duke's classification, the lymph nodes, the mesentery, the lesion, etc. Look at this particular picture. This how is it? Here there is a bulging lesion which will have to be examined and deciphered before it is being opened up. Thanks to Chicago Medicine. They have done a beautiful job in this particular one. So there is a stricture that is shown over here. And in this, there is a region of thickening or fibrosis. It can again be due to any kind of a chronic inflammation. We can mistake it for malignancy. And for any kind of a lesion, you people should feel the lesion and see the symptoms, almost like cocaine abuse. Thanks to web pathology for this picture. Look at this one. I'm able to see a colorectal carcinoma. This region is quite far off and it is free of tumor, whereas here it is friable, a lot of narrowing is seen, and there is also a thickening of the wall. And the surgical resected margin is only a few centimeters or even 1 centimeter away. Therefore, this will be of paramount importance than this. So mechanically, do not do one margin after another. You people will have to be judges. Or it can be ulcerative lesion and an ulcer, ulceroproliferative, whatsoever. Here, the edge of the ulcer, it is projecting above the surface and I'm seeing the floor of the ulcer. The other mucosa, how does it appear? Courtesy web pathology. Finally, I come to what is called the opening up. So there is an inking of the surface. As I told you, the surface can include serosa, it can be the mesocolon, and finally it can be the muscular region. And after opening up, look at this one. Before opening also, I'll be able to find out the lymph nodes. There are different groups of nodes. These are called the paracolic nodes. This is a higher group of node, and this is the apical or the highest. Generally, a surgeon will be tying a knot in this region to help us follow it. But then there are multiple groups and drainage which we should very meticulously try to identify. So this is the lesion, the bit is given. Generally, it said that the entire surface should be given and the region of the maximum thickness also. Also from other regions, just for comparison and for completeness. And the resected margin. In this, what they have done is correct. They have taken it perpendicularly so that the normal histology is displayed. But here what happens is there will be a inner longitudinal and an outer circular because of the interchange that is done. This is the importance of the cut surface. Usually I used to think about the longitudinal surface, but see what happens. Here the tumor is causing the mesoappendix and it is being entering the peritoneum. So this will be important and the lymph nodes that are being involved. Always a complete sampling will be required. So look at this one again. This is the lumen. There is a tumor. The tumor is invading the wall and the surrounding face shape. Sometimes it can go behind also. So behind we have got just a nerve bundle, connective tissue, and then the bone because it's a spine. The types of excisions are there. It can be total mesenteric excision or there can be other things such as the areolar plane and the visceral fascia that are being done. Lower anterior resection, abdominoperitoneal resection, and en bloc. The entire mass is being removed. This will have to be applied to the various circumstances. For example, in this case, there is fibrosis and then there is adhesion. So both the loops will have to be sampled. And what we are seeing over here is a diagrammatic one that I had been explaining earlier. What will be important will be the bare area and whether it is involving the surrounding tissue. The right and the wrong method of doing. Always, I told you people, there will be a fat and then there will be a plane of division and then there will be a muscle externally. In this case, there has been a thorough sampling, therefore, there is no node that is left outside. This appears more proper, the proper plane of cutting. Whereas, look at this one. In this case, it has been cut improperly, therefore, a positive node is left outside, which can again lead to a recurrence. This is a surgical problem, but the pathologist will have to be aware of it. So this is a stricture and the addition that I had shown you earlier. The Duke's classification, kindly go back and read whether it is going to be confined to the mucosa, the lamina propria, or it is extending into the muscular layer, traversing the entire wall and the serous. So this will be important for us. And this is a normal histology. Kindly compare it with the tumor over here. This is another one. Earlier, I had shown you a picture of what are all the relative structures. Anteriorly, we have got the bladder, posteriorly the rectum. And there's a very beautiful picture in which there is a tumor. Of course, it is there throughout. But then these are tags of fat. Therefore, this is the rectum, whereas this is the bladder wall. The tumor is extending from the rectum to the bladder. That is what I am seeing in this. So there is a tumor, there can be a fistula, so sampling will be of great importance in such regions. So this is the flipping and the painting that will be required, and then the external examination that is mandatory. This I had already shown you people about the serosal nodule. And when I do take the bits, it has to be a transverse sectioning, the tumor will have to be there, and then the depth of the tumor, to what extent. What the author says is, it is not the size of the tumor that matters, but the depth of the tumor. The prognosis will be depending on, one, the depth of the tumor. Two, it can be involving the lymph nodes. Three, if at all it is going to be histological, you find that undifferentiated tumors and small cell tumors will carry a bad prognosis. And if it is going to be close to the resected margins, downwards will have to be made up. So this is how the sampling is being done, thanks to the Royal College of Pathologists, Australia. Multiple parallel ones, they say at least 4 through the tumor, and the depth will have to be assessed. So there's a flower-shaped tumor, this is how it is being done. And of course, from the resected margins and so on, so forth. What is important? As I told you, they say that only the mesocolic nodes are important, the next group will be important, but then the apical is not very important, particularly when it is near the bifurcation of the blood vessels. But what happens in this particular case is, these nodes are all negative, whereas the apical node is positive, a classical skip lesion which we should be aware of. Therefore, these are all the regions from which bits should be given. Have an idea about it. Thanks to World Journal of Gastroenterological Surgery. Thanks to WebPath for these pictures. In this, I am finding an infiltrating tumor, and the wall is quite tenacious and stiff. For this reason, the patient will be having complaints of constipation and will rush to the doctor much earlier. And hence, this is supposed to be of better prognosis, but otherwise, histologically, both the cecum and the descending colon have got the same prognosis whatsoever. Again, please do remember, Tinea coli can be found over here, and Linitis plastica is another condition which is not limited to the stomach itself, but can be found in the colon. So there is very stiff one, and there is a narrowing. This can be again mistaken for other lesions. Luckily, we do not have a Crohn's disease, which can have a similar appearance. In this, there is a total ulceration of the mucosa, but still there is no exophytic growth that is present. Rather easy to make out, but unfortunately the lesion is extending up to the rectal mucosa. So these will have to be taken into account while sampling. The histology is important. As I told you, it is only the depth of invasion and not the other things, unless it is poorly differentiated. The lymphatic drainage we have already mentioned, and there are different groups of nodes. That can be the paracolic, and then it can be the common iliac, internal iliac group of lymph nodes. We should be aware of it. The number of nodes. This is usually a dilemma and a question that is asked. As many nodes as possible. Do not be satisfied with 2. Many books or references say at least 12. But if you do get 18, kindly sample all the 18. And you find that if it is going to be less than 5, the entire cut surface. If it is going to be 1 centimeter, part of the node can be embedded. The remaining part can be left behind. And the maximum grading, it will be matter when we do the reporting. And there is a schematic picture that is there, showing the epithelium or the mucosa, then there is a submucosa, muscularis, serosa, and the lymph nodes. As I told you earlier, there can be different levels of these lymph nodes. It can be starting right from over here, but it can be external, extramucosal. And this is again a beautiful diagram wherein you find that the artery, vein, and the lymphatics all join together. That is why the bare area and the sampling will be important. And there is a mesenteric border which should not be tampered with as much as possible. Here I find that the first group of nodes is being involved. So it can be progressively becoming the stage 2, stage 3, and stage 2C. The normal structures. One thing that I should be having in mind will be the sphincters, rather the surgeon. He is very particular about it because if the sphincter and the levator ani muscles are being cut, they won't be functioning and the bowel will lose its continence. And there is a tumor over here. When they do a surgery, they have got all this in mind, and we should be able to cope up with that. This is the levels of painting that will be important for us to identify the different regions and the extent of involvement of the tumor. Serosa, mesorectum, and the muscle. We rise by lifting up this. I thank you all for the patient listening. Kindly do a meticulous work in home.